Hello, good afternoon, everyone. You're welcome for this webinar. We're just giving a few minutes to some of our colleagues to join and we'll start off.
Richard. Hello.
Dr. Deo, you're welcome. Can hear you.
Yeah, I hope you can. I've had 8 minutes of a challenge of joining. I don't know why.
Sorry about that.
So I think, can we start?
Yes, please. Yes, we can proceed.
Sorry, Deo, I think, sorry, Deo, one of our presenters, I think the first presenter, that is Clare. She's not yet she's doing the case presentation, the pediatrician from Soroti. I think she's not, I'm not sure if she's yet on the panels yet. I don't know if we sent her the link as a panelist. I'm not seeing her on the panel as yet.
Claire was here. I think she just dropped off. Let me reach out to her quickly.
Okay, that's fine. Just reach out to her. Okay.
She's back. She's online now. Claire, confirm you can hear us and can speak to us.
Yes, I can hear you. I sent the presentation to Richard to the email. Have you received it?
Yes, Claire, let me download it and project as the moderator takes on the webinar this evening.
So Richard, I hope we can speak and everyone can hear us, especially the attendees. I hope they can hear us. Look for someone to ask.
So they can confirm in the chat if they hear us or not. Anyone?
Okay, so Maurice has said they can hear us clearly. So good afternoon, everyone, and welcome to the Neonatal Sepsis and Antibiotic Stewardship webinar. This is under the auspices of the National Stewardship of the Newborn Steering Committee. Today we have a range of topics we're going to discuss, and we're going to start with a case presentation by Dr. Clare Nakubulwa, who is a pediatrician, and she is one of the awardees. I think she got a Heroes Medal or one of those nice medals that she got for her work she has done in Soroti Hospital. So Claire, you're welcome. We're also going to have a talk by Sister Sarah and Dr. Gerald, and then we shall have Dr. Jessica, and then we'll wrap up with 2 talks by Dr. Catherine and then Brenda. So you're all welcome to this session. And I would like to ask Claire to begin with the case presentation. Thank you.
Yeah, thank you so much for the opportunity. I hope you can hear me. Hello, can you hear me?
Yes, we
all
can.
Right. Yeah, first of all, we'd like to appreciate the team for choosing Soroti Regional Refferal to present a case. We don't take it as a small thing, so thank you so much for involving us. So with me, I'm with Sister Alekat, Sarah Gladys, the in charge of the NICU. And in the presentations, I'm going to present it with her. There are some parts that she'll present and some parts I'll present. So the person helping us with the presentation, you can move on to the next. Yeah, so this part, she's going to present it and then I'll briefly go through the case. Thank you.
Thank you so much. Hello. Are you getting me? Fine. I feel so much honored to be part of this team. Well, we have a case to present here. Soroti Regional Referral Hospital, NICU, was opened in February 2021 as an independent unit. At first, the neonates who were sick used to be managed in a side room in maternity and another smaller room in pediatrics, but it didn't have its own management. It's not until last year, February, that a unit of its own was opened, and I'm working as the unit in charge. The NICU of Soroti Regional Referral Hospital has a bed capacity of 13 beds, but out of these beds, 5 are radiant warmers. So it's a small space, but at least it's operating on its own. On average, NICU admits 105 sick newborns as inpatients, and neonatal sepsis takes up 28% of the admissions. In the NICU, Soroti Regional Referral Hospital, the major contributors to mortality is birth asphyxia and prematurity. On clinic days and other outpatients, it has become an order now whereby people know there's a neonatal unit. So anything to do with a sick newborn, they come to the NICU. We see on an average 45 outpatients in a month. The NICU is run by 3 established nurses, such that the nurse neonate ratio is 1 to 20. It's quite alarming, but we thank God we are pressing on by His grace. Thank you. Next.
Yeah, thank you so much, Sister Gladys. I'll just briefly go through the case. So this was a baby of AF, a female baby who was born on the 28th of May, 2022 at 11 a.m. and was admitted a day later, that was on the 29th, and it was at 11:30 a.m. So the age at the time of admission was 24 hours and 19 minutes. The baby was 2.9 kilos at birth, was from Gweri, Soroti, that's the mother, and the mother was an 18-year-old para 1+0 who had stopped in senior 2. We didn't have the details on the father. Next slide. So the presenting complaint for this baby was fever and not breastfeeding well for 6 hours. So this was a term neonate who was delivered by emergency cesarean section because of obstructed labor, who cried immediately at birth with Apgar scores 8 and 9, breastfed well within the first hour of life, and then passed meconium and urine within the first 24 hours. However, later on, the parents noticed that the child developed fevers that were high grade associated with lethargy, but there was no reported abnormal movement, no seizures, and no excessive crying. So the child also had poor breastfeeding, however, didn't have any vomiting, didn't have any abdominal distension. So in the other systems, there was no yellowish discoloration of the eyes or skin, didn't have any cough or difficulty in breathing. Antenatally, the mom had attended antenatal care twice and started at 24 weeks of amenorrhea from Gweri Health Center 3, which is near to where she stays. She received Refferal, she received IPT 2 times, and then also got a TT injection once, and also got Mabendas or so. From the antenatal card, they had done the HIV, syphilis, malaria tests, which were all negative. However, hepatitis B surface antigen, blood group, sickle cell testing, and HB had not been done. So she reported that the pregnancy had really been uneventful. She didn't fall sick during the pregnancy, had no bleeding, no PV discharge, no rash, and didn't need any hospitalization. She was generally okay during pregnancy and didn't have any known chronic illnesses. So at the time of delivery, the mom was referred from Gweri Health Center 3 because of obstructed labor at 39 weeks of amenorrhea. So we didn't have the details of how long the labor had taken, but there was a positive history of maternal fevers at the time of delivery. And she was given IV antibiotics before, just prior to the cesarean section. And at the time of delivery, it was noted that the liquor that was there was foul smelling. However, it wasn't meconium stained. So when we examine the baby on the neonatal, so I'm giving the examination at the time when the child was admitted. The general condition, the child was sick looking, was febrile at 38.0 degrees Celsius, had dry mucous membranes. However, the capillary fill was less than 3 seconds. In the other general exam was fine. So the head circumference was normal for the age at 34.5 centimeters. The weight was had dropped down to 2.75. kilograms, had an intact spine and didn't have any dysmorphic features. The genitalia was female. She had a normotensive anterior fontanelle. The pupils were equal and reactive to light and had a good suckling reflex with the Moro and grasp also being present. So in the respiratory system, didn't show any signs of respiratory distress, had a respiratory rate of 54, which was a bit like on the borderline of normal, of upper normal, and had equal air entry with bronchovascular sound. So the saturations at that time was 94, that was on room air, it was fine. So the CVS, parabdomen, those were the findings, and musculoskeletal, there was no abnormality noted. So the impression at the time of admission was a 1-day-old female-term neonate with early onset neonatal sepsis, giving how the symptoms, the time in which the symptoms started. So the management plan at that time was doing the nursing care, stroke monitoring, doing a complete blood count, fluid and feed. So the child was put on IV dextrose because it was the first day of life. The child was put on D10. And then also the mother was supported to continue breastfeeding since the child had a good suckling reflex at the time of admission. And then the antibiotics were started according to our protocol, which is IV Ampicilling at 50 milligrams per kilo twice daily, and then Gentamizing 5 milligrams per kilo, and this was given for 7 days.
Well, nursing care, one, since from the history, the baby had a high grade temperature. Upon admission, we maintained the baby, we exposed the baby and did tepid sponging, and also empowered the mother to continue with the tepid sponging whenever the baby felt hot. We also had 6-hourly fluids as per doctor's prescription, D10 for 24 hours, and we monitored breastfeeding. Support mother to breastfeed. We had to keep encouraging the mother to breastfeed the baby. Vital monitoring was done and drug administration as prescribed by the doctor.
So in the labs, we're only able to do the CBC, we're unable to do CRPs around here, and the lumbar puncture wasn't done for this particular baby. But from the CBC, the only thing that was a bit out of range was the PCT and then the platelet count that was slightly elevated. Otherwise, the complete, the white cell count, the neutrophil count, and the HB were within range for age. So this chart shows the progress on the ward. You notice that we only have one recording. So this is the record, these are the vitals as were recorded at the time of the ward round. So we see that for the first 3 days, we still had high grade fevers and our heart rate was a bit high, like on the upper side. However, the respiratory rate, the saturations remained stable. So from the 4th day, that was on first, up to when the child was discharged, we had normal temperatures, and even all the pulse rate was normal, and the saturations, oxygen saturations were normal. So the child was given medication, and on the 7th day after getting the last dose, was discharged in a good state, was discharged on routine care, and the review was PRN whenever needed. So yes, the presentation is done, but this is just to give us a glimpse of the mortality trends for the Soroti neonatal unit. For this time, you'll see that neonatal sepsis has, although it contributes like the highest number of admissions, it's kind of contributing the least to mortality. So in 2021, it was about 13% of all admissions. And now in 2022, it has gone down to about like 4% of all mortalities at the unit. Yes, and that marks the end. That just shows our reception area for the mothers. Yeah, we encourage them to put on laces as they go in because we don't have uniforms for them. But that's their waiting area. That's where they wait from as they come in to breastfeed their babies.
Thank you, Claire, and thank you, Sister Sarah. I would like to open up for a few questions or comments before we move on to the next presentation. You can either raise your hand or type into the chat.
Yes, hello, good afternoon.
Go ahead, Tony. Dr. Deo, we have two people.
Yes, I've seen Evangelist Tony and Jennifer Damoy.
Okay, thank you so much, Soroti Regional Referral Hospital, for the presentation. Generally, the management of the patient was optimal, though there is a simple observation I made, which I'm seeking for inquiry. After 48 hours of administration of antibiotics, I saw you continuing with the first line. And yet the protocol says after 48 hours, when you still have high fevers, you actually need to take off blood for culture to establish if you can go to second line. How did you go about that? Thank you.
Okay, can I answer that?
We could take Jennifer's as well.
Okay.
Thank you so much, Claire, for that management. I think on my side, it's not really a question, but a comment. I'm glad that we, for now, maintained the antibiotics, the ampicillin and gentamicin. Reason being, you began with the first line. Reason being, in my practice, in many places, you realize that I don't know why people seem to be abandoning the first line antibiotic, and have seen some neonates in some places that by the 5th day they're actually neuropenium. So I'm just glad that even after the days of ampicillin and gentamicin, I still feel comfortable that this works and the patient is discharged in a good general condition. Yeah, thank you.
Thank you for that comment. And it was a very important observation. So maybe Dr. Clare, you can comment about that before we move on to the next presentation.
All right. Thank you so much, Dr. Jennifer, for that comment. And thank you so much for the first person who asked. So yes, why did we continue ampicillin and gentamicin after 48 hours? So we have a general protocol. So the idea is that we don't have blood cultures at Soroti Regional Referral, so we are basically depending on the clinical picture of the patient to determine who we treat with what. So the general guide is that after 48 hours of appropriately given and appropriate doses of the first line, which is ampicillin and gentamicin, if the child is still very sick and is still spiking fevers, we move on to our second line. We don't have blood cultures, but for this particular patient, from the clinical examination, though the fevers were still there, the child was not so sick, was otherwise breastfeeding well, just had those episodes of high fevers. So that's why we decided to continue with the first line. And after the 3rd day, we didn't get any recorded fevers, and the child continued to improve until discharge.
Claire, there is a question about the prescription patterns of paracetamol for neonates. Could you please comment on that before we move to the next presentation?
Fine, thank you. In NICU, according to the treatment guidelines, we don't use paracetamol in most times, unless if it is a surgical case. We basically do the tepid staging and exposing of the neonate.
Thank you very much. And also, I think it is a big reminder to all of us that dehydration in neonates can be a major cause of fevers. So rehydrating by breastfeeding, depending on the level of sickness, would be very helpful. So thank you all for the comments and questions. I would now like to invite Dr. Gerald Ojambo to give his presentation. Gerald, you're welcome. Gerald is a pediatrician and a neonatal fellow from Kitovu Hospital. Thank you.
Thank you. Thank you, Deo. Good afternoon, everyone. I hope I am audible enough. My task is to give a brief review of the sepsis series, especially regarding categories, presentation, diagnostics, investigation challenges, and the issues on antibiotics. We'll start with a bit of a background where we appreciate that sepsis actually is a major player in mortality. In as much as Soroti says it has gone down, yes, that's good. But worldwide we see it contributing up to 15% of neonatal deaths, and 99% being in the lower income settings. And we know that significant reduction in infection-related deaths will bring us closer to achieving our SDG 3. Regarding the burden, the sepsis varies depending on the setting you are in and what population you are looking at. But on average, one of the studies that was done recently, it was a prospective cohort in several facilities in many countries, about 12 facilities in 7 countries. And the study was published in the Lancet in May. It gave a clinically suspected sepsis incidence over 166 per 1,000 and a culture diagnosis incidence of 46 per 1,000, which were relatively high compared to the data we have from the high income settings, as you see in the slide, of 1 to 4 in the US and 6 in Canada. Next slide. So in Uganda, a community incidence of 11 was demonstrated by one of the researchers in the Kawempe community, and in the regional and district hospitals around, we see a higher prevalence, just like Doctor said. Clare said that they have a high prevalence. The reason for admission is very high. Sepsis accounts for a high proportion of admissions. Just like here, we see 39.1, 36.1. So it's a relatively common problem. Mortality, case fatality demonstrated in Mulago by a study done by Josephine et al. Was 9.5. Which relates very closely with what was done in a multi-center trial also, the Neonatal study in which Uganda participated, which gave a mortality of 11.3. But a high mortality was observed in those who were culture positive, 17.7. Next. So definition, there is no global consensus, but generally, most research use a clinical definition of a newborn with signs and symptoms of infection, with or without accompanying bacteremia. And that is what has been used. So the classification is basically early onset or late onset, depending on the time of presentation of this child. The early onset being within 72 hours, like the case that was presented, and late onset after 72 hours. Some clinicians will opt to use a 7-day period, especially for the term babies, but generally for the very low birth weights and preterms, we use a 72-hour cutoff. The key here is pathogenesis is different, and the organisms might be similar, but the pathogenesis is different, and there may be differences in management, especially when it comes to organisms that you may suspect. So in the early onset, the pathogenesis is basically vertical transmission from the mother to the baby, and in the late onset, it's horizontal, where the baby gets infections from the caretakers in the community. In the hospital setting, we know in the hospital setting there are lots of procedures that were done. I'm sure the baby went through IV insertions, and also being in the NICU alone, you'll actually pick up some bugs that are not on you. So vertical transmission basically means infections in the mother can be transmitted to the baby, and also as the baby is born, they get as they go through the birth canal, they pick up infections, and also any other procedures that could be done intrapartum. Next slide. So risk factors are very key because they actually will help in predicting decision to treat or not to treat. Some of these risk factors can clearly, there are a multitude of risk factors from studies done, but we can clearly separate them into those that are maternal and those that are neonatal and others. So maternal factors are very key when it comes to early onset sepsis, where you see like those highlighted. Preterm birth usually occurs because of infections like chorioamnionitis. We have hospitalization of the mother, illness in the mother, a low socioeconomic status has been implied. Infections like bacteriuria, UTI, maternal discharge, early rupture, premature rupture of membranes, more than 18 to 24 hours has also been considered a high risk factor for early onset neonatal sepsis. The neonatal factors include key is of importance is the birth weight. Low birth weight and preterms are at high risk, and also the scores at birth. Those that score low actually are at very high risk of getting neonatal sepsis. A study by Josephine, again, the study we looked at, puts cesarean section as a risk factor for a culture positive sepsis. That is something worth looking at. Next slide. So late onset factors, basically like we discussed, is environment, what you're doing to this child, those that take so long, the newborns that take so long in your facility. You have to do the IVs, the lines, the feeding tubes, sometimes medication. And important to note is, I think people prescribe ranitidine or some antihistamine or PPI blocker, and this puts the child at risk of sepsis, especially. Now, we need to, next slide, please. So which organisms are we looking at? Organisms, according to studies done in Mulago, you can see that, yes, Staph aureus is the biggest culprit, both in the early onset and late onset. And this is closely followed by E. coli. You can see that Staph aureus is majorly in the late onset, although it is the highest overall, and E. coli predominantly in the early onset. Here, this was a study done in 2020, published 2020. I want us to compare this to another slide. The next slide, please. A study done earlier in a similar setting. This is a study done by Mugalu et al. In 2006. Again, we see Staph aureus leading, again, predominantly in the late onset, although it is the biggest, it is responsible for most of the infections overall. E. coli is the major bug in the early onset. Here we see a GBS, which we know is has a high prevalence. Studies have given up to 28% colonization in mothers. But we see here, we see GBS. In the previous slide, we did not see GBS. And here, we don't see any Klebsiella it is not very key. Whereas in the previous slide, you can see that the numbers of Klebsiella have gone up. Next slide, please. So this slide shows the early onset infections, non-hospital acquired. Again, from the multi-center study done, this is a Neonatal study we talked about. Again, giving E. coli as the biggest culprit, early neonatal, although it also closely following are the Acinetobacter and Klebsiella. And we can see Staph aureus still playing a big part, and GBS at 0.7%. Next. This is in the late onset. We see the biggest proportion of organisms now is Klebsiella pneumonia. So we need to appreciate that it is getting more and more common, and we also see coagulase negative Staph. Staph aureus also still being in the picture. So we notice a changing pattern in our organisms. Next. Here on this slide, we can look at the last two where I wanted to emphasize that GBS is still with us, in as much as we're not culturing it a lot. We need to appreciate that GBS is there with us. And again, Klebsiella, this was the study by Pinaki in rural India, which shows Klebsiella is still playing a very big role in neonatal sepsis. This was a community study, but Klebsiella was playing a very big role. It was the most predominant organism among the gram-negatives. Next. So clinical presentation. Clinical presentation, in summary, is really non-specific in sepsis, and it may range from just subtle symptoms to overt, like hemodynamic collapse, such as a child in shock. Next. So some of the symptoms you need to really look out for, even at the outset, look out for subtle symptoms. When a mother complains about some symptoms, don't take them lightly. Look for subtle changes in the baby's behavior. Baby's irritable, baby's not feeding, baby. So it is good to look for all these. So fever, or hyper or hypothermia, hyperthermia, particularly persistent, like we saw in that child, is a very important feature of sepsis. We can have failure to feed, breathing problems like respiratory distress or apnea. A poor perfusion is very suggestive, although this appears as a late sign. We can have CNS signs of lethargy, poor sac, seizures. If you observe, do blood sugars in these babies, you'll find they may have hypo or hyperglycemia. There may be bleeding in these children. And also there is that hardening of the skin that may come, and so this will actually be is more like an ominous sign. It's a late sign of presentation for sepsis. Next. So diagnosis by clinical criteria has been, should I say screening, has been done, and that is what is emphasized majorly. And the study, this is findings from a study by the young infant group, showed that some signs are actually highly sensitive. They are sensitive, relatively sensitive for severe illness, but not close to 100%. Anyway, so they still, and they're not specific at all. So in as much as we know that neonates with signs and symptoms require prompt evaluation and initiation of antibiotics, we should know that clinical signs on their own may not be sufficient to tell us if it is sepsis. There may be different things going on: anemia, the respiratory distress syndrome of preterms, bleeding in the brain, and so on, or even heart diseases. So a full evaluation should be done, and that involves history, assessment for risk factors, a thorough clinical examination, and laboratory testing, really. And you should bear in mind that this should not delay your initiation of antibiotics. Next. So which investigations are we talking about? We're talking about tests that should be done. The one that would ideally want, that would be definite for sepsis, is the blood culture, and that is the gold standard and should be done prior to initiating of antibiotics. So a sample must be taken off properly. You should have the proper specimen, and using the aseptic technique, withdraw the right amount of blood, about 1 ml, and then also make sure that results will come out within two to 3 days for where facilities are available. And so the moment the blood is taken off along with other bloods, then the treatment can be commenced. CSF culture can be done where it is clinically feasible and it is safe with no contraindications. The reason we want to do the CSF is because we need to optimize the antibiotic therapy. We need to decide if that is what we need to give. Sometimes these babies may have meningitis that is not actually showing. 25% of bacteremias actually may have CNS involvement. There may be CNS infection, but not clinically seen. So other cultures that could be done, urine culture is not useful in the early onset because of the pathogenesis, it will be resulting from the bacteremia, so the blood culture will do. We can only do a urine culture in the late onset sepsis. We can do aspirates or swabs of secretions, particularly like tracheal secretions. If you have a tube in place or you have a wound with a discharge, then you can do the swabs for those wounds to see what is causing. Next. The non-culture tests, we have the CBC as was done, but the CBC is a test that you need to know how to interpret, because it has a lot of things around it. The white blood cells on their own will actually change as the child is, it varies with gestational age. So you need to know the gestational age, the postnatal age, and correlate them properly. It is not a one size fits all. And then also it is important to note that at the time around birth, the values may go high normally for a normal child. And so you cannot make a decision if this is early onset sepsis because based on your CBC. So you need to be mindful of those changes in the white blood cell counts. But if you look at the next slide, please, you can see that there's something. It is once you have parameters like you see in the slide there, a very low white cell count is very, very specific. A very low absolute neutrophil count is very, very specific. You can see up to 90%, 99%, you know. So these are best used more like to strengthen your diagnosis for sepsis, but you cannot use a CBC to identify or to predict sepsis in a newborn baby because many of them will have sepsis even without the CBC, even when the CBC doesn't show. Back to the previous slide. The other test is the CRP. We've looked at the platelet. I will not talk very much about it, but let's look at the CRP. The CRP is a good test to do because it is relatively more informative, especially if you're doing several tests, not one test, but several tests. And it is best assessed after 24 hours. So we're looking at a time frame of about 48 hours. It rises at birth, but it plateaus, and it rises also with the infection. So anything causing inflammation will actually cause it to rise. So in as much as it might be good to tell us if there is sepsis, there is also, it also has many confounders. For that reason, it is not specific. Although it's important to notice, it helps us to decide when to stop treatment, because if you please go forward 2 slides. Next slide, yes. If you look at that table, you can look at the CRP on day 1 and day 2 and their sensitivities. You realize that on day 2, at around 48 hours, the CRP is actually quite sensitive, and it's actually better if it is done serially. And it can actually be able to tell you that if it is negative, then there are chances that that baby may not have an inflammation of sepsis going on in that child. And because of that, it can be used to actually make decisions when regarding the duration of treatment of antibiotics, not in isolation, but in conjunction with clinical findings and along if especially like blood culture was negative, like you can see some studies were done, as shown down there, where 84 culture negative patients had their antibiotics stopped after 48 hours because their CRP was low, and there was no clinical relapse in a space of up to 4 weeks. So it is actually useful in helping to stop treatment. Next. Other investigations are basically supportive to either localize the infection or find out complications resulting from the sepsis. So you can do sonography, x-rays for looking for pneumonias, x-rays of the abdomen for NEC. You can do the bleeding workup in case the child has a tendency to bleed, and then you can do blood sugars. All these are tests to help in management. Go on. When it comes to diagnosis, so diagnosis is definitive diagnosis is a positive blood culture, but as you will see, the catch rate is not very high. In this study, you can see that was done 46 of the clinically suspected patients, 166 patients suspected, only 46 had positive blood cultures. The Neonatal study also had only 21% culture positive rate, and also the study done in Mulago had only 12.8%. So the catch rate is actually very low, averaging about 1 to 3 to 4 actually. So that's one of the problems with the blood culture that we have. But it does not necessarily mean that in negative culture, in a negative child culture, a child actually does not have sepsis. So all these are the challenges when it comes to diagnosis. So to evaluate a child, we need to look critically at the risk factors, the history, the pregnancy, labor, and need to do a full thorough examination and do the tests and use all this to help us arrive at the decision. Now, when you are actually making a decision to start an antibiotic, that is, if you think your child is sick, you need to have, these are guidelines from NICE, South African guidelines, where any of these actually, if a child has any of these, you would consider this an absolute indication to actually start empiric antibiotic treatment. Empiric, as you actually do, like we said, at this point, you need to do a blood culture before you actually give antibiotics. So empiric treatment should be given to those suspected if a twin was sick, was confirmed or is suspected to be sick. Respiratory distress, severe distress requiring mechanical ventilation, seizures, shock, definitely shock, and infants with moderate to severe HIE, because studies have shown that these babies are up to 36 times more likely to have sepsis. Next. If this is another option where you look for some of these factors and look for any two of these if they're available in a child in your assessment, then you can actually start your antibiotics. This is an extraction from the South African guidelines. Continue. So when we actually make, when we've done our whole assessment, we'll actually end up concluding that this is presumed sepsis if the baby is unwell, but our sepsis screen is negative. So you still have the clinical picture. The clinician may actually, the clinical picture might still suggest that the baby is actually unwell, but the septic screen is negative. So that we may still go ahead with the presumption of sepsis. Probable sepsis is when you have a clinical picture along with risk factors and or just a septic screen that is suggestive of sepsis. So one of the two. Then proven sepsis is definitely the culture that is positive. Next. So management, like was seen, is basically supportive. There is supportive and definitive. In the supportive, we've looked at what was done for the baby. It aims at ensuring proper temperature management, feeding as appropriate, good oxygen control, good oxygen support as required, management of any complications that arise, ensuring that the child is hemodynamically stable is also important. Continue. And so we might need to use fluids or even use drugs to maintain hemodynamics, to maintain the child in a stable hemodynamically, and support the respiration as required. Continue. So this is basically care. Now, specifically antibiotics, we cannot overemphasize the need for antibiotics because they have played a very big role. Like you see in that slide, they actually have reduced, they've played a significant role in reducing mortality. This is a graph that shows the trend of mortality in US that was the early 20th century. It drastically fell when antibiotics were introduced. So we cannot downplay the role of antibiotics. Continue. This slide is basically showing a small survey that was done in a few facilities and around us, and the WHO recommendations for the antibiotics to use. Now, ampicilling or Xpen, along with gentamicin in combination, are the preferred choice. First line, because they target the expected organisms, GBS, gram positives, ampicillin or Xpen, and then the gram negatives from the maternal genital tract. Second line is third generation cephalosporin, which may be cefotaxime or ceftriaxone. Cloxacillin might be added if there is a suspicion of a staph infection. So as you can see, the different the facilities, what they had in common was the first line has been the first line, with the exception of Zambia that are considered Ampiclox, which is still a penicillin, but for the purpose of targeting staph aureus, which might occur as a first line, as one of the organisms happening in the early onset sepsis. Differences occurred in the second line and in the third line, but these are really because of, I think, the decisions that they have to make regarding adverse reactions of the drugs, regarding the pictures that they see, and also the availability of which drugs they have to use. So this is still in the multi-center study. The options that most of these facilities had, this is not Uganda alone, but Uganda is inclusive. But important to notice, you can see that early onset sepsis, gentamicin and ampicilling still have a very big role to play. Next slide. Regarding antibiotics, this has to be started within an hour of decision to treat, and guided by specific factors like the onset. We've seen the early onset, ampicilling, gentamicin is preferred. Likely pathogens, again, coverage of both gram negatives and gram positives, and if necessary, if you suspect or if you have reason to suspect, like Staph aureus, then you will include that. And the antibiotic susceptibility patterns in the area and the cultures. Adverse effects also have a role to play. Here, if you look at ceftriaxone and its effect, displacement of bilirubin from albumin and likelihood of causing jaundice, people opt for cefotaxime. And but also there are also issues that have been discussed with cefotaxime. Classes of drugs commonly used are the beta-lactams, which are the cephalosporins and penicillins and the carbapenems. So you have the ampicilling, you have the X-pain, you have the cefotaxime, and we have the carbapenems and meropenem. Aminoglycosides like amikacin and gentamicin. The glycopeptides are drugs like vancomycin. Next. The next question is how long to treat? How long to treat for? There is no clear information. I haven't come across many studies in that area, but just like one of the studies that had already been mentioned was the study where CRP was being used to determine duration of treatment. And so if the decision to treat when when the culture is negative and the CRP is negative, a decision can be made to stop treatment as early as 48 hours. And you can see that there is minimal relapse actually, but one study showed the outcomes to be good when they actually treated positive cultures for more than 7 days, and they stopped those with negative cultures. They stopped again around the same time, but antibiotics were stopped earlier for those who had the CRP negative and the culture negative. Next. These are decisions that have been made. Some studies, actually, some protocols indicate, especially like in early onset sepsis, GBS, they'll give you an average of about 10 days. It depends on the condition also, and if you're treating meningitis or a bacteremia. And if you're treating, is it a deep-seated infection? Some of these can go on, treatment can go on for long, beyond 10. If culture negative, we have seen that you can actually use the CRP to actually guide, and we can stop if we have no clear indication to really continue. Next slide. So about the resistance patterns, we are continually seeing changes in options being used in the treatment, especially for the when we see little improvement, or even people are adopting first lines which are different from Ampigent because of their resistance patterns. But this study to look at the resistance pattern, we see in Mulago, we see resistance to ampicilling of up to 73.9 and gentamicin up to 23.9. Ceftriaxone is still sensitive. Next. Globally, if you look at a review done by several studies in East Africa, you will see that the rates here are much higher and more alarming, with ampicillin having resistances of up to even 100% among gram-positive infections, ceftriaxone up to 50%. So they're really, really high. And we need to actually be mindful of resistance that is actually going on. The mechanism of resistance is basically one of selective pressure, where we are using continued use of these antibiotics even where they are not necessary, use and overuse. And studies even indicate that sometimes we treat babies, for each baby that was treated that required treatment, 23 others were treated and they did not really require the antibiotics. So we are getting to a point where we should not have just cover antibiotics in these babies. Next slide, please. So it is known that at one point every drug will have anti-resistance achieved. But what we know that is that what we can control is the time at which we actually get the resistance. If we use the drugs well, these drugs are able to serve us for a long time, but you can see that most of the drugs, even the newer ones, there's a lot of resistance coming in. Next. This is a study in Pakistan, which shows you how amikacin is, how most of these drugs, amikacin, piptaz, imipenem, these are drugs that you'd consider probably third generation, second generation, second line, third line, but you can see the level of resistance that is actually being reported in these studies. It is really, really alarming. Next. In conclusion, basically, neonatal sepsis is still a burden we should appreciate. We are looking at common pathogens and their changing patterns, as we have demonstrated. Diagnosis is still a challenge, but we can use the investigations we have and make informed decisions, okay? And we've also seen that antibiotic resistance is steadily increasing. Thank you very much.
Dr. Deo Munube, or Dr. Victoria, you can pick it up from here.
Okay. Dr. Ojambo, I would like to thank you very much for your good presentation. I think we have had quite a number of clarifications made. We've been able to get the definitions of early onset, late onset, the common organisms, and actually what investigations we can do. And you've also been able to tackle a duration. If a baby just has maybe a fever, CRP is normal, how long should we treat? If we have a positive culture, how long should you treat? And some of the drugs, common drugs that we can use in our scenario, given the fact that sometimes actually we don't have all the necessary diagnostic material that we need. And you've also ably emphasized that we need to have antibiotic stewardship. We need to have a first line, second line, and third line. The ideal is that we should at least have a culture, but sometimes we don't have cultures to be guided in our management. But it's important that we know what is our first line in our institution, when we do our second line, and when we do our third line. So do we have any questions before we go into to the next presenter? Do you have any questions?
We have two hands, Dr. Victoria.
Oh, sorry, I'm not seeing the hands.
Alex
There is
Afeti and Elizabeth Asungo.
Okay, in that order. Thank you. In that order, please. So Alex, Betty, and Elizabeth. Yes, Alex? Please, Alex, ask your question. Alex, is Alex there?
I think he's failing to mute. We can move to Elizabeth and Albert.
Okay. Can we have Elizabeth? Elizabeth. I don't know. Am I missing them or something? There is Elizabeth, please. Okay, can we have Albert, since Elizabeth is not, Albert, please, your question.
Yes, thank you very much for giving me the opportunity. Thank you very much, Dr. Ojambo, for your presentation. My question was about the organisms. It seems, I mean, it's quite interesting, and I want to ask Victoria, why is it that we are seeing a lot of Staph aureus also as the causative organism in early onset sepsis? Could this be a challenge about the collection of samples during these studies, especially the ones which are in our region? Or is it something that is actually unique to babies in this part of the world? Because if a baby has Staph aureus sepsis, those babies, I'd assume, are very ill babies. Thank you.
Okay. Thank you very much, Albert, for your question. Yes, it's true in most of our studies here in Africa, actually, but specifically in Uganda. Staph aureus is one of the common organisms that has been identified. It has been identified, I think, in one of the studies in Mulago by Dr. Mugalu, and I think another study by Nakubulwa recently. One, it could be the way we collect, but also it could be one of the organisms that maybe is lying around, maybe as people are delivering, maybe we are not doing effective infection control as people are delivering. So that could also explain why we have the early onset sepsis. Yes, sometimes the babies that have Staph aureus may be ill, but most organisms that cause severe illness are gram-negative organisms, especially Klebsiella and E. coli. The gram-negatives tend to cause more severe disease actually in the newborns compared to the gram-positives. That's the answer I have for you, Albert. So another question, that is John Bosco. John Bosco, please.
Thank you very much. Am I clear?
Yes, you are.
Thank you so much. This is John Bosco, Assistant DHO Chiruhura, MCH, and I'm glad to be here. I was following closely and looking at the appalling resistance percentages for most of our antibiotics we use here in the primary health care system. But I have a few things to note. One of them is that there's not enough regulation in the use of antibiotics, especially when we go to the private sector, where it is stylish to give the most recent antibiotic regardless of the guideline. Two, there is a lot of quackery, which I think the NDA is not doing much about. Maybe lastly is a question, how widespread is this resistance? Because I would have loved to see the patterns where this resistance is mostly widespread, and we see how to guide our facilities in how to adapt to the challenges. And maybe it's high time we updated our Uganda clinical guidelines, because I can see some more antibiotics are as good as useless. Thank you very much.
Thank you very much, John Bosco. Over to you, Dr. Ojambo. You can be able to answer some of those questions and any other panelists. Thank you.
Thank you very much, John Bosco. Regarding, I think the question there was where is the resistance, but are these resistances being really registered? It is, I think, I don't know if it is a very obvious question, but I think what we have is studies done in facility settings, like as reported by Josephine and even the Neonatal study. We have not gotten information regarding antibiotic use and their resistance, because their publications are yet to come out. But the facilities register resistance, but we believe this is because it's the same organism anyway. I would imagine if we have a high resistance to penicillin, so especially Ampicilling, it does not vary very much. Other studies in Kenya, in Uganda, are all giving about a picture of about 75%. The figure of 100 was quite alarming for gram positives, but I think they cut across. It is just, I think, how things might come. I don't know how to. I think it is just everywhere. In summary, ampicillin resistance to gram positives is ampicillin resistance to gram positives. We do the studies in the facilities, but they can be representative as to what is happening. Thank you. I welcome any other addition.
He's also asked about guidance, I think, for the private sector, because I think they also need to have some bit of antibiotic stewardship to know what drug they can use as first line or second line. Bosco, I think what you've said is very right. Many times people want to give the most recent new antibiotics as for the infections. So it is, I think, upon the Ministry of Health to do education and to reach out and to give guidelines within the private sector to ensure that antibiotics are given appropriately. Thank you. Thank you. If we don't have any more questions, I suggest we go on to the next presenter. That is Dr. Jessica Nakibuuka. She is a neonatologist, newly qualified from the University of Cape Town, and she's from Kawempe Regional Refferal. Please, Dr. Jen, she's going to talk about antibiotic stewardship, and I think this is what we all need to make sure that we can use antibiotics appropriately. We need to make sure we have a diagnosis, have the right drug, we give the drugs using the right route and the right duration. Dr. Jessica, you're welcome. Thank you.
Thank you, Victoria. Good afternoon, everyone. I assume I can be heard properly all over the place.
Yes, you're very clear.
Okay.
Thank you.
Thank you very much to the previous speakers. This is going to be easier for me. And my discussion will be about antibiotic stewardship. And the question is this a new thing? I've enjoyed the deliberations we've had from the case presentation onwards to the questions. And we all agree infections in our newborns are a common cause of death. And it is quite alarming that it is still an issue, even in this century. All hospital neonatal units that look after small and sick newborns, and that includes preterm babies or at-risk babies, must ensure they respond and treat all serious infections early and appropriately. So in come antibiotics. We know they are life-saving, but as we have seen, and as I am going to speak, they have known potential negative effects on young children or young babies or neonates' natural defense systems, natural growth pattern, In so many ways, they're affected negatively. And if used for prolonged periods of time and incorrectly, they may promote the development of antibiotic-resistant strains of bacteria, the so-called superbugs. That's the conversation we've had. And I actually had someone say, are all these antibiotics useless? It is a yes and a no, as we shall see. So the antibiotic stewardship program is one way of looking at whether our patients, who are the neonates in this case, are getting the right antibiotics at the right time for the right reason, and whether these antibiotics are stopped at the correct time. It also looks specifically if antibiotics are stopped in a timely manner when there is no good clinical indication initially, or there is no microbiological evidence for a bacterial infection. We can say antibiotic stewardship programs are a way to relook at what we as healthcare workers do to minimize spread of infections in our units, in our hospitals, and to ensure that all healthcare workers use antibiotics in a rational manner or rational way. So let's look at it as a way, a police unit within our NICU, a policing group of people in our unit who guide us what to do to avoid all the above issues we have talked about. The slide before you just shows what a blood culture would look like. That's culture, different cultures growing different organisms. The previous speaker has explained explicitly, it is the gold standard. But how many units have access to this? How many units are going forward to treat these very sick babies in the absence of a culture? Well, I don't know. We'll find out prospectively. So the outline of our conversation today on antibiotic stewardship, we are going to define the terms of what that is. Why is antibiotic stewardship important? And is it a problem to us? Is it a problem in our units, in our hospitals, in the private sector, public sector? Why is it a big problem? And what can we do to make things better, to improve our practices? So you will find interchangeably, the literature does speak about antimicrobial stewardship. Sometimes they say antibiotic stewardship. When they say antimicrobial, they're looking at all the different microorganisms, all those pathogens, viruses, bacteria, fungus, etc., etc. But when they talk about antibiotics, they're focusing on only the antibiotics, which is our topic of discussion today. So don't be strained to conform to either definitions. They've been evolving over the years. So what is an antibiotic stewardship program? It is a coordinated intervention that is designed. Remember, it is coordinated. There must be a unit in the hospital focusing on that. It is designed to improve and measure the appropriate use of antibiotics or antimicrobials by promoting, one, the selection of the best or optimal antimicrobial drug regimen. This is usually guided by the unit guidelines or national treatment guidelines. The dose of drug given, is it the correct dose? Is it according to the weight of this baby? We are speaking about duration of therapy, a very important concern that has come up and is still a gray area. And also it looks at the route of administration of this drug. Do you have to go IV? Do you have to give it orally? Which is the best way to ensure it's available to the baby? But at the same time, they're safeguarded against secondary infections coming through your portal of entry. If it's an IV cannula, the skin is broken, anything can walk through that. That is just Staph aureus we are talking about. Next slide, please. So we go on to define what appropriateness means as per the definition of antibiotic stewardship. I borrowed the slides from a WHO manual on antibiotic usage in health facilities, and the issues they speak to are, one, is it the right indication to use the drug you have chosen to give? We do select the appropriate drug to give depending on the pathogen or organism we have cultured, if known. But as we have seen, it's quite a challenge in most units to have a blood culture. And remember, the turnaround time isn't so quick for you to make a decision. You must start antibiotics immediately you think they're indicated. We can't wait for the turnaround time of a culture. So we must start. And what informs this decision? So the issues like the site of infection, we must consider that even in the absence of a pathogen, the way we treat meningitis will not be the way we will treat a UTI. We must look for a drug that optimally concentrates in that tissue. Otherwise, we are not doing anything if we choose drugs that are not the right fit for the right condition, suspected or confirmed. The right drug must be chosen. We must choose drugs which have a spectrum that will cover what we are thinking about. We've been talking about ampicillin. It is age old, it is here to stay. Because you're looking at GBS sepsis, when you look at ampicillin, it's an early onset organism that is in the mom's tract. So it is transplacental or it is transferred through an ascending infection to the mom. So it's always mom's habitat, it's mom's body, and it only responds to ampicillin. Don't be tempted to veer away from ampicillin. It is not an expensive drug, and maybe that's why people think ampicillin is cheap, let me go to ceftriaxone, it's stronger, but you are missing the point. GBS sepsis meningitis only responds to ampicillin, whose CNS penetration is great, and then you're targeting sepsis and meningitis. So do not think certain drugs are inferior just because maybe they're cheaper or they've been around for so long. We have to consider the right dose of drug. That speaks to the baby's weight, ensuring that if there's a loading dose, it is given and the correct maintenance dose is given at all times. And we follow standard recommendations about that drug in the unit. Appropriateness also speaks to the right frequency for the drug. Give it at the correct time, the right dosing at the same time, every day. Then last but not least, the right duration. When the prescribed drug has been administered for the correct duration based on the patient's diagnosis or clinical status, we can then think of stopping the drug. But this also can be informed by a discussion within the unit as to what we think that baby had, even if they have improved subsequently. If it was meningitis, we cannot treat it in less than 10 days. No. If it is sepsis, we may do that. So it all depends on your degree of suspicion, high index of suspicion, what organisms are common in your unit, if you have microbiograms, and commonly how do your babies present, and which category of babies come, preterms or term, how do they present? That can guide us on what appropriate drug to choose, following all these parameters I have mentioned. Next slide, please. So I go back to the question, is antibiotic stewardship something new? It dates back to 1940. This followed the discovery of penicillin by a gentleman called Ian Fleming in the 1920s. He incidentally discovered penicillin, and that is our ampicillin today. It still works. Antibiotic stewardship programs have been in existence for a long time and have been implemented at various degrees with improvement over time. Earlier forms of antibiotic stewardship programs focused on cost. We used to worry about how expensive a drug and how we should use it or not use it. Maybe the doctors who studied in early 80s, 90s do remember conversations around, but how expensive a drug is to give it to a patient. That has evolved, that has changed. We're no longer looking at the finances as we see what's happening now in Kampala. People are giving drugs anyhow, in any way. Maybe some even look at the parents and say they can afford a drug A and they give it to them. So it's all many influential things going on, but that's not the point. We are no longer looking at the cost of a drug to decide who gets it. The antibiotic stewardship programs that are done can be done either by restricting use of reserved antibiotics or doing prospective audit feedbacks, as we are going to see how those are done. And they're possible in our different units, as far north in Uganda, east to west, south. These audits are possible. Next slide, please. Why are we concerned about giving antibiotics? We know they are good. They have been here for a long time. They treat our children. If you're in doubt about a baby's condition, give them an antibiotic. Isn't that what we are doing? I've seen that happen myself. So the concerns are, antibiotics are the most prescribed medications in NICUs all over the world for early onset sepsis. Evidence has shown overwhelmingly ampicillin is the most prescribed drug. At any point T, we will find over 97% of babies in the NICU on ampicillin. And that speaks to our concerns for early onset sepsis. But is it true that moms have sepsis when they have these babies? Antibiotic stewardship has been born out of our serious concerns regarding raising antibiotic resistance, partially due to the overuse and misuse of antibiotics. There is the dilemma on the decision of treating a presumed sepsis, as we have seen. Evidence, however, is showing that almost 60% of the antibiotics prescribed within the NICU are done without an appropriate indication. People have a gut instinct, people have a heart instinct, maybe wherever the organ is they're thinking with, they'll say, I'll give this baby an antibiotic. Informed by how they feel or what their tummy is saying, they will give a baby an antibiotic. But we have seen 60% of it is not appropriately indicated. There's excess use of broad spectrum antibiotics. This has been associated with own consequences, as I have mentioned, a resistance to specific antibiotics or specific antibiotic classes. We're now going to the imipenems, as we have seen. These are third line, these are down the line, but we're pulling them to the forefront as second line or first in some institutions. And this is not good for us. We need to reserve a drug that will do things for us when other things fail. So we cannot start with a drug that should be down the line as our first drug. We know the consequences to the babies. So when we promote a rational use of antibiotics, we are trying to say, we are increasing resistance of organisms. The superbugs, they are not responding to conventional antibiotics, the cheaper ones, the available ones, because we have cleared what they call the microbiome or microbiota. This is the normal immunity, the normal environment in our babies' bodies or tummy or the bloodstream that is naturally protective as a barrier to many organisms. But when we give them antibiotics, we kill off the good guys, we kill off the good bacteria, the protective ones. And what does it do? Our babies then are opened up again for an increased risk for late onset sepsis. And in the preterms especially, we see an increased rate of necrotizing enterocolitis because all the good bacteria are gone. Now the bad ones come in, invade the baby gets septic and very sick, usually they die. So it's because we are doing these things and we're not really rationalizing them. We see a longer hospital stay, a long duration to be discharged. We see increased cost to the hospital, not only in terms of the drugs, but the personnel, the nurses, the time for the doctors to round, the time to mix these drugs and give so many babies. We take away care from the actual sick babies who should be getting care in the unit to others who are needlessly getting these drugs. So it is costly to us if we do not have a stewardship of antibiotics in our different units. Next slide, please. So is antibiotic stewardship a problem to us? Yes, it is. The conversations earlier have indicated that we have the limited investigative opportunities. I'm not sure I've seen a culture in some hospitals for a while. It is a problem to us also because we have restricted patient monitoring. Sometimes some people, some clinicians here will handle high volume numbers of sick babies. They'll not be giving each baby a quality time to actually take a good history, examine baby carefully to decide actually it is infection causing the issue. The nursing staff who could give you recordings of what's going on with the baby too may be strained as they're running around giving antibiotics needlessly to other children. They will have no time to monitor other babies. So when they find they're really sick or they have de-escalated or deteriorated, everyone will say sepsis and they give them sepsis. Rather, they give them antibiotics, you know? Units do not have devices to monitor these babies so that alarms can flag us whether a baby with a high temperature is actually sick or is actually lying on their, is actually overheated in their incubator or overswallowed or dehydrated. Units don't have such monitors to tell us how baby is doing, either airway-wise, when they see quickly respond to an apnea, quickly respond to something. We don't have these monitoring devices to speak to us. It's the only way babies will tell us they're unwell, so that we don't touch them needlessly, we minimally handle them, and in that way we don't expose them to the E. coli in our nails sometimes, or the staph aureus on our skin. We are touching them all the time. We're not monitoring them effectively, and usually it's because the numbers are quite large and the few teams on the ground. We also lack optimal newborn care practices in our units. It is not unusual to delay enteral feeds with breast milk for various reasons. Mom may be sick or unwell, post C-section, no breast milk yet. We do go for prolonged parenteral nutrition. Those IV lines stay there for a while as we give our D10, D5. These are the portal entry for organisms we are talking about above. They will go through this device. There is use of invasive interventions and devices. The UVCs in our Nicu'S, right through the umbilicus, the UVC creeps up right into the heart, you know, and Staph aureus is on that device. It tracks along that device. So what are we doing correctly or incorrectly in our units? Let's look around and see which baby needs IV drugs and or does not need them. Which baby should be breastfeeding or feeding on breast milk, either by cup or either way, that should have started like yesterday, but they're still on enteral feeds. Who are the champions for breastfeeding in our units that should go and look for these moms from day one, support them to lactate, express, give us milk? So as you see, the interventions are minimal, low cost effective. They are possible in our units to get teams speaking to moms, to give us milk, for teams to decide whether IV parenteral nutrition is needed, whether IV lines should stay there or be removed as soon as indicated. A UVC, I would like to note, I've seen that practice is not a conventional IV access for babies. Unless it's an emergency, use it. And as the baby settles, as you have more hands by the day team, more teams have come in, remove the UVC and look for a line peripherally anywhere on the hand or the foot. Don't leave a UVC there for more than 24 hours. It's only indicated for inotropes, as the clinicians here do give. And if the inotropes are not weaned in 72 hours, then something is wrong with that management. So a UVC is not an alternative to our peripheral line. It goes so deep, it introduces all these sepsis. Maybe that's why we have a lot of Staph aureus. So the other challenge we have, the evidence base is growing, but slowly. We have seen local evidence. Dr. Mugalu, can we have the next slide, please? Mugalu et al. Did a study in 2002 that has been mentioned by the previous speaker that looked at etiology, risk factors.
Jessica, you're muted.
Hello, can you hear me? I got dropped off a little. I'm just speaking to the local data that we have and previous speakers talked about the organisms in our NICU. A lot has been done since 2002 by Mugalu et al. We do see Josephine et al., as the previous speaker has spoken, show us neonatal sepsis in Mulago, show us vaginal colonization with bacteria and women in labor. And again, the trend is the same. We're seeing all these resistant bugs, the super bugs, MSL, CRE, colonizing mother's vaginal tracts. So potentially these neonates too are at risk for sepsis from the same. And again, it speaks now to antibiotic choices. Such babies with these ESBL, MDR, and bacteria will not respond to conventional antibiotics. But again, I'm trying to reiterate, the data is not strong. It's like we should have every 3 years some data to guide our national guidelines on sepsis management coming out to tell us what is actually going on and what we should do. So I would call on our postgraduate students, if there are any on here, to take the lead at least. Every 2-3 years, inform us what's going on in our NICUs. That way we can inform our practices. Next slide, please. So again, when I said, what can we do? All hope is not lost. It is possible to implement an antibiotic stewardship program in our different units, and there are 7 key elements that we must consider in our NICU. Most importantly, leadership. There must be a team chosen by us, people in the unit who are keen, interested. I would advise everyone to be interested. The pharmacists should be in there, the clinicians should be there, the nurses, the infectious disease specialists, if a hospital has one, to guide. Microbiologists are in Mulago, they can be contacted. All these work together to collaborate how to go forward. And they can do this through prospective audits and feedback, that is review of broad spectrum antibiotics on day 3 for every baby, and know which babies must stop antibiotics if they're no longer indicated. So the duration too, like I said, may be determined by a team sitting together to discuss, especially in the absence of a culture or other investigative opportunities that we don't have. We can always put our heads together and actually agree together what we should do. There's what is called antibiotic timeout, physician-led approach to review antibiotic indications on a bi-weekly basis, and monthly teaching sessions for people in that unit. We can have our diagnostics and laboratory testing. Those are the cultures we talked about. We can use our CRPs, procalcitonin markers. All these inflammatory markers can tell us a lot what we are dealing with or not dealing with. One of the speakers mentioned we can do serial checks and stuff, but we advise for the neonates, we can keep chasing these labs or abnormalities to the end. If we keep chasing labs, you can chase a CRP for a while, and that will say you keep the baby on antibiotics until you have a normal CRP. It's very important to put your foot down and say, we have this baby here clinically in front of you. This is what you think, and this is how long they'll be treated for. But if we keep chasing the labs and all that, sometimes it's a rabbit's hole. We will not stop chasing them because inflammation takes a while to really resolve. So the clinical pathways are guides that ask physicians to enter signs and symptoms, provide recommendations for antibiotics. It is beneficial in diagnosis when treatment guidelines are well established. So we can also have those ways of putting our symptoms in a certain format, and we discuss them. The computerized decision support, the computerized decision support, where we can use our electronic decision support to use antibiograms and patient data to generate and discussions on antibiotics and recommendations. The lab can put all these abnormal labs together, growth, culture, tell us in the unit what organisms are growing in our hospital. That can inform us. And last and most importantly is infection control. There's known preventative strategies like hand washing, hand hygiene, using soap and water, or alcohol rub to clean our hands. Contact or droplet precautions are very important. And with COVID-19, we did see an improvement in that as people wore their masks and washed their hands. So we do look to good things to come eventually as we improve very low cost things like hand washing in our different units. It will go a long way in helping us. Staph aureus is on the skin. E. coli is a gut organism. Where does E. coli come from to get into our hands? It is in our nails, on our watches, in our palms, on everything that we wear, and then touch the babies. So that's just a simple graph of who can be on the team for antibiotic stewardship. Obviously, clinicians must take the lead as the teams. The hospital pharmacist must be on there. He or she should support with review of patient files for antibiotics used. And that way we can tease out if we are adhering to our protocols on antibiotic usage and give feedback to people. We must have an infection prevention control nurse or microbiologist or doctor or anyone in the team who sees to it that people wash their hands, people are trained, they attend CMEs, and then we always give feedback at every opportunity that we have to the teams. So the team is a basic team, and units can do that with each one having their role clearly expressed to them. As next, please. So how to conduct antibiotic stewardship programs? There are so many ways. One of them is known as the point of prevalence survey. It is a one-time activity where the unit can say, every first Monday of the month, we sit together and review patients' files admitted in the unit at the time, tease out who is on antibiotics, why they're on those antibiotics, and for how long. WHO and the European Center for Disease Control, CDC, have very good tools that I'll give you in my references that you can use. You don't have to reinvent the wheel. Go use those guidelines. They just ask you the time baby was born, the hours when they started antibiotics, which ones and why. Then we also have the prospective audit feedback. This one too is an add-on from the point of prevalence survey. Here it's ongoing from what we did on every first month of the month. We continue maybe at 3 monthly intervals to assess our adherence to protocols on antibiotic usage, and feedback is given to all the health workers in the unit. That too has tools which are basic and simple to use in some of our settings. There's what is known as the auto stop tool, and for advanced centers that already have good established antibiograms, antibiotic stewardship. In this facility, there's an auto stop tool is designed whereby the hospital pharmacist is given access to patients' lab results, and they can review and stop issuing the antibiotics unless there's a documented reason to continue with the treatment. So they're like our guards. They tell you, you didn't grow anything in the lab, but you're still prescribing antibiotics. You're coming for them for this baby. How come that is happening, yet you didn't grow anything? So it's like a stop or a check, but it only works if we correlate the lab with the pharmacy and with us. So it can happen in hospitals that maybe can afford this tool. It is affordable, it is there. And then there's a combination of all the above, where some units will do the point of prevalence survey, a one-time thing, or they may do it prospectively. You know, add many ways together to pick information and create a database which will inform their antibiotic practices. Next slide, please. So can antibiotic stewardship program be done in our Nicu'S, our neonatal units? They don't have to be ICUs, remember, can be any unit caring for newborns. It is possible, and we have seen barely none have been done in Africa, so it's a potential area for research. WHO, other partners can invest in that, see what is happening on the ground in the units in Uganda. We shall use the WHO recommended tools above, and then what can they do for us when we do them? They improve the quality of patient care by rationalizing antibiotic usage. They will promote mother-baby bonding, early initiation of breastfeeding so that we cut out the formulas, the NEC. They'll reduce hospital costs by reducing admissions, antibiotic usage. The staff time needed to treat these children or give them antibiotics is a lot. And then to promote earlier discharge. So it is possible in our units to do these things. And then we only stay with babies who must be in the unit, the HIE and preterm babies. And then we do away with sepsis eventually. Next slide, please. So point of prevalence, I've mentioned earlier what can happen. We can go on to the next slides. It's simply looking at what we do in the unit, hand washing. This is what the tool looks like. We prepare as a team together, engage authorities in the hospital, train people, capacity build, use those tools by WHO, we collect our data, have preliminary results, and disseminate the results locally within our units, and even to other national partners, eventually to see that they can support us in the units. But as long as we don't know what our gaps are in our Nicu'S, we may not be able to go very far with these efforts. We need to know what is going on in the ground in our unit for us to make a proper antibiotic stewardship program. If it is a unit that constantly has no running water, the sanitizer runs out, there's no soap, then let's start there. Let's not quickly go to these tools unless we've sorted our housekeeping. That is one way we shall go with antibiotic stewardship programs. So the next slide, and I conclude. It's been quite a long day and a lot to take in, but should you forget everything I have said, WHO has 5 moments for every one of us on hand hygiene. The first one is wash our hands before touching the patient. The second one is before touching the patient, before a clean or aseptic procedure, we wash our hands. The third one is after body fluid exposure or risk, we wash our hands. The fourth one is after touching a patient, we wash our hands. And the fifth one and last one is after touching a patient's environs. Our stethoscope, our thermometers, our phones in the unit, mobile phones, clean them, sanitize them. Babies do not move from the incubators. It is our hands that move. It is us who move. Babies do not move. So the organisms are in our hands. And if they find a baby with an IV line, meaning the skin is broken, the organisms, Staph aureus will get into their skin. E. coli from our fingernails that are not cut will get into the baby, and it is our practices. Remember, baby, our hands. The last slide, please. So always remember, handle antibiotics with care. Yes, they should be handled with care. If you forget everything, think twice before you start antibiotics. And last are my references. I want to thank you. This is a very useful manual from WHO that will guide all of us in our units to start somewhere with caring for our newborns. So I thank you very much for listening to me, and I welcome any questions, suggestions, or remarks. Thank you very much.
Thank you very much, Dr. Jessica, for your useful presentation and guide on antibiotic stewardship. And do we have any questions concerning antibiotic stewardship? I can see some hands are up. We have Arinda and Immaculate. Arinda, your question, please. Your hand is up, and Immaculate Mirembe. Okay. Arinda, Immaculate, can we have then Dr. Tom, if those are not able to give us the questions? Dr. Tom, please. Dr. Tom. It's as if most of the people that have put their hands up, either they are not able to unmute their microphones. So we have Arinda, Immaculate, and Dr. Tom. Please, can you ask your questions?
Hello, thank you very much, Dr. Victoria, and thank you, Dr. Jessica, for that wonderful presentation. I just didn't have any question to ask, but I think just the hand raised up accidentally, but I think this is a useful presentation, and thank you very much, Jessica, for it. Thank you.
Welcome, Dr. Idiamo. I think in Hoima you will start the NASP team very soon.
Okay, I think we don't have any more. People may have put their hands up accidentally, but I think this is a very useful presentation. And as we all know, neonatal sepsis is one of the major causes of morbidity and mortality. As we try to implement our interventions in reducing prematurity and asphyxia, if we don't pay attention to infection control and antibiotic stewardship, sepsis usually goes up. And they have rightly said, the main issues are clear, like infection control, antibiotic stewardship. Each of us can be able to have a team for antibiotic stewardship in our units. We can form a team where we draw our own local protocols. We know when to start the antibiotics and when to stop, when to give the third line and when to give the second line. That is basically what the antibiotic stewardship team does. Thank you very much, Jessica, for your very good presentation and guide on antibiotic stewardship to the Ugandan health workers. So if we don't have any more questions, I think we move on to the next presenters, and that is Brenda and Professor. Let's go to the next session, please. Thank you.
Brenda, you're muted. We can't hear you.
Thank you so much, everyone. I'm privileged to be speaking after most of the previous speakers who have been fortunately been taught by or guided by, and I hope I don't distort most of what they've just presented. So this will take a pretty short time as just a summary of what has been presented, linking clinical outcomes to research for neonatal sepsis and antibiotic stewardship. These are research repository summaries, and they will be shared together with the rest of the presentations after the session. So it will follow the guideline of the presentations, which was started with a case presentation, presentation, diagnosis and management, and lastly, antibiotic stewardship. So moving on to the neonatal sepsis and antibiotic stewardship with a focus on the case presentation. Literature that has been pulled out, recent literature for May 2021, September 2020, markedly here, would like to show a study by Helgera Repeto et al. Done in 2020. This study developed a model for diagnosing early and late onset neonatal sepsis based on clinical, maternal, and neonatal data at the time of clinical suspicion in the NICU. This particular model was intended to assist the bedside clinician without the rest of the tools needed for quick diagnosis, with simple clinical criteria that identify patients with suspected sepsis the day of clinical suspicion. On this particular study, some of the most important findings from it were the top 10 factors estimating sepsis were maternal age, maternal cervical vaginitis, and the neonatal factors included fever, apnea, platelet count, the gender of the baby, the complete blood count, cell pattern, catheter use, and the birth weight of the child. And the most important of these that were highlighted were the maternal age, neonatal fever, and the platelet count. While this study model was limited to the study center that was used, a lot of this study would need to be replicated in other settings to see whether it replicates this, the same factors estimating sepsis at the bedside. And some of the key variables for the diagnosis of neonatal sepsis, of course, including early onset sepsis and late onset sepsis. As we've highlighted, this study specified maternal age, neonatal fever, and platelet count. So hopefully we could be able to replicate this in our setting. And then moving on to the evidence from WHO, a cohort study done in Nepal, September 2020, was published through WHO on adherence to WHO guidelines for treatment of early onset neonatal sepsis in low to middle income countries like ours. This study examined the treatment of early onset neonatal sepsis in hospitals in Nepal. And findings from this study showed that 75% of the neonates were treated according to the guidelines. The study used data on antimicrobial treatment of neonatal sepsis within 72 hours from 12 regional hospitals. And the guidelines, the guideline group included early onset sepsis neonates treated with ampicilling or benzalpenicillin, while the group that didn't use the guidelines included neonates treated with all other antibiotics. From this study, it was revealed that cefotaxime was the common alternative when guidelines were not being followed, something highlighted by one of the speakers. And some observations from this study was there was moderate adherence to antibiotic treatment guidelines for early neonatal sepsis in this particular low resource setting. And adherence was influenced by the facility size. And so the chances of following guidelines were higher in the larger facilities as compared to the lower facility. In a study that was recently published in May 2022, again on early onset neonatal sepsis and antibiotic use in Indonesia. This study examined the characteristics of early onset sepsis and antibiotic use in NICU'S. The incidence of early onset sepsis was reported at 9.6% and was mostly due to gram-negative bacteria. And as again earlier indicated by the previous speakers, ampicilling or amoxicillin with amikacin were the most frequently prescribed antibiotics in hospitals with culture facilities, while a third generation cephalosporin was commonly used in facilities without culture facilities. So in conclusion on this study, early onset sepsis was defined as neonates presenting with 3 or more clinical signs or laboratory results consistent with sepsis and who received antibiotics for 5 consecutive days. And here the authors pointed to the need for prospective antibiotic surveillance and stewardship interventions. And then just again on the management modalities, as well as neonatologist perspectives of management of neonatal sepsis in settings such as ours. A survey of neonatologist management perspective of early onset sepsis. So this study was conducted and explored management perspectives of early onset sepsis among neonatologists. It was conducted in Peru, and most participants were tracking. It was found that most participants would rather track the fever and do a sepsis workup instead of prescribing antibiotic therapy for low-risk febrile neonates. And also the participants in this case, I would say the neonatologists, revealed that they would do a lumbar puncture in neonates with seizures and early onset sepsis, but few would do the lumbar punctures in cases with positive blood culture. Furthermore, the findings showed that ampicilling, amikacin, was the most common first-line drug combination for early onset sepsis, followed by ampigenta and then ampicillin cefotaxime. So the observations from this study highlight that there's a variation in the approach to and management of early onset neonatal sepsis among practitioners which exists. And this therefore necessitates and strengthens the need for local standardized protocol to minimize unnecessary procedures, antibiotic exposure, and bacterial resistance and prolonged hospital stay for babies. Then a study with a special focus on Uganda, Astoga MC et al. Published a study in 2019 on preventing neonatal sepsis in rural Uganda. And this one involves some of the modalities for infection prevention, as Dr. Jessica highlighted, that the babies don't move. It's us that move our hands from the babies, each of the babies, or from the bassinets or from the Nicu'S. So the study assessed if addition of bitterants and perfume towards the external baths. Results showed high perfume formulations, and so infection prevention at all Nicu'S and provision. So these particular slides that have the tables shows just a running PowerPoint, a running PDF that has all the articles that were pulled out for this specific webinar on neonatal sepsis. And lastly, the evidence for antibiotic stewardship. A lot has been spoken on it already. The prospective study by Bernards in 2021, a study on effects of antibiotic resistance, drug target attainment, bacterial pathogenicity and virulence, antibiotic access and affordability on outcomes in neonatal sepsis. So this international microbiology and drug evaluation prospective sub-study was conducted to assess the use and efficacy of empirical antibiotic therapies commonly used in low to middle income countries for neonatal sepsis. From the findings, ampicilling, gentamicin, ceftazidime and amikacin, piperacillin, tazobactam and amikacin, amoxicillin, clavulanate and amikacin were the most commonly prescribed antibiotic combinations. This study also recommended considering accessibility and affordability when advocating for antibiotic treatments in low to middle income countries. The findings also showed lower mortality among neonates treated with ceftazidime and amikacin compared to those treated with ampicillin genta. So the observation found from this study is there are a number of antibiotic combination therapies used in the management of neonatal sepsis in various LMICs, but there is some notable resistance to ampicillin genta due to its long-term use over the years and antibiotic misuse, which may no longer be effective as the years come forward and as we face more challenges with antibiotic resistance. And the rest, I guess we could take some time. Dr. Jessica spoke about the rest of the studies that have been done around the continent and globally, and we shall also share what we found this as shown on the PDF on the screen here. Thank you so much, and that's all we have from linking clinical outcomes to research.
I would like to thank all the presenters. That is, we want to thank Clare and the nurse from Soroti Regional Referral Hospital. And I would also like to thank I would also like to thank Dr. Ojambo for that extensive review he did on the clinical presentation of neonatal sepsis diagnosis and the different organisms that cause neonatal sepsis and the culture sensitivities within the continent and also Uganda. And I also like to thank Dr. Jessica for ably discussing and presenting about antibiotic stewardship. I think this has been one of the very, very important webinars that we as the neonatal team from the newborn committee have really been able to do very well. And I believe that many of us have understood that newborn and neonatal sepsis is a major cause of morbidity and mortality, whereas there is an increase in the antibiotic resistance, jumping to like drugs like Ampicilling being our first line, Kifotaxim being our first line, using meropenem as our first line is not going to help us. It's going to just increase hospital costs to the patients, and then final patients will not be affording to pay. It's important that we have appropriate guidelines and protocols that can guide us in our units to know which is our first line, which is our second line, which is our third line. I know many of us do not have, cannot do blood cultures, but we can be able to use the current guidelines that are around, and we can be able to use the knowledge that we have gotten here to have antibiotic stewardship teams in our units to ensure that that we adhere to those principles to reduce on the antibiotic resistance. Hand washing is not expensive at all. All of us can be able to hand wash. We can be able to minimize the number of times we touch our patients. These are some of the things that we have highlighted. I was concluding for us to stop this webinar, but I can see we have Christine has her hand raised up. Christine, please. Christine.
Vicky, sorry to interrupt. I just wanted to add that if we could take maybe one or two questions from the chat before we close, it would be quite good. I think there were a few questions.
I hand over to you, Deo. You can chair now. Thank you for joining us. So, Deo, please go on with the chair.
So we had a hand up. I think we can entertain the hand quickly.
There was Christine. I don't know, Christine, someone? No.
Christina, are you still on? And Immaculate, are you still on? Those are the hands that were up. Immaculate Mirembe, please ask your question or give your comment as we wrap up. I hope you can. I hope you're not having a challenge with your network. Immaculate, you can unmute. You can unmute, please.
Yes, thank you very much for this wonderful CME, all the presenters. I had left my question in the Q&A. It's basically about what's the final take about prophylaxis in early rupture of membranes. We've been having the practice of giving antibiotics routinely to these babies, but some of them we find that they are symptomatic, and definitely from the presentations, it's contributing to resistance. What would be the take on it? Because we also find a lot of resistance from the parents, even when there was clear early rupture for more than 24 hours and plus. And unfortunately, some of these babies at times come back later with infections, while others don't come back with infection. Thank you.
I will request Jessica to answer that, because she gave us some good explanations with regard to rational use of antibiotics. So Jessica, can you give your comment on prophylaxis when it comes to early rupture of membranes?
Thank you very much for that question. It's quite common in our environment to see this. The evidence says confirmed rupture of membranes for more than 18 hours in a preterm baby is an indication for antibiotics. It's not speaking to the term baby because then they are term, they should be born anyway, but it mostly speaks to the one who is born preterm. What is causing that preterm labor for them? And they specifically point to one who is 36 weeks or less. That one is a high suspicion for antibiotics to be started. And then ideally, we shouldn't have room for prophylactic antibiotics at all or empirical antibiotics ever in the NICU, but the limitations we have point us to more of a history in the mom now. She's had early rupture. Did she have a fever before? Did she have draining before? So that we make the diagnosis of chorioamnionitis clinically, and then we can start our treatment and look at how baby is doing in the meantime. Also, there's if you're in a term baby who is more than 24 hours, or rather for more than 24 hours before the onset of labor, that too is an indication to start those antibiotics. So it's to do with the liquor, the amniotic sacs around the baby, rupturing, draining, and all, exposing the mom to an ascending infection. So yes, you can start the antibiotics, but prophylaxis is not treatment. It means you have a guarded timeline to stop them. Then treat the baby rather than prophylax, treat them fully for at least 5 to 7 days if you have a CRP guiding you in the setting or a CBC to add on. But we also know the limitations of all these things. So bottom line is a history in mom, fever, draining, and the flag is what caused these things to happen before time. That way we can be pointed in that direction. And again, I would like to say it's a case-by-case issue. It's important to consult and ask people about it. Thank you.
Thank you, Jessica. And I think you have ended with the most important part about consultation and asking a second person when you have a doubt on what you're doing. Thank you very much. I would like to end by thanking the Newborn Steering Committee and thank all presenters and thank Richard and the team from USAID, FHI, and St. Francis Hospital. Thank you so much in Zambia. Have a good evening and have a blessed day. Thank you.
Pleasure. Thank you, Deo. Thank you, everyone.
Thank you.
Thank you, Deo. Thank you,
Thank you, Richard. Thank you, Brenda.
Thank you.